most of the excitement right now is looking at inhibitors of FLT3. Okay, and those drugs are furthest along in development. We know that 25 to 30% of patients with AML with normal karyotype will have activating mutations in FLT3, typically in internal tandem duplication. We know that there are a number of drugs that can inhibit that FLT3 tyrosine kinase. And from monotherapy studies, FLT3 inhibitors have been shown to have efficacy in terms of decreasing blast counts. No drug is FDA approved in this space yet. We do know that sorafenib, which is FDA approved for hepatocellular carcinoma and renal cell carcinoma, has activity in FLT3 ITD positive AML, especially in relapses post-allo transplant. This has been published in Blood, a small series of 6 patients showing high response rates in these post-allo transplant relapses with single-agent sorafenib 400 milligrams twice daily. So clearly an off-label use of that drug. The drug that's furthest along in clinical development is quizartinib, used to be called AC220. Quizartinib is a FLT3 inhibitor. As monotherapy, again, it has shown high response rates. I do have one concern about the presented data, and that is the responses tend to be mostly complete remissions with incomplete marrow or incomplete blood count recovery. So I'm a little concerned that these might be tantamount to patients clearing their leukemia without count recovery afterwards. However, having said that, this may be a very important drug for bridging patients to an allogeneic stem cell transplant, which would be the only curative option for patients with relapsed FLT3 ITD positive AML. So that drug continues in clinical development. There is a mutation that can develop in patients who respond to quizartinib. The D835 mutation can develop. Another drug that's in early clinical development is crenolanib. Crenolanib is active against both the FLT3 ITD and the D835 mutation.